All right, thank you guys so much for having me. It's a real honor to be here. I know asthma is not the sexiest of the emergency medicine conditions, but if you work and see kids in a non-tertiary care center, it's probably the #1 reason you build critical care. And though it's straightforward most of the time, it's worth thinking about those cases than when it's not. Like this kid who rolls into your ER at 2 a.m., a 3-year-old, a history of bad asthma, been intubated before. He's quiet, calm, anxious-looking, a little diaphoretic, and his chest is totally silent. Now, the main challenge to taking care of sick kids is recognizing them right in front of you. If you don't have kids, this is what a 3-year-old ought to look like. So any child who's too calm, too cooperative, letting you do stuff to them, you have to be suspicious they're harboring some really serious illness. And we talk a lot in peds about examining kids from the door, and that's necessary but not sufficient. You have to do a close exam with intention, get them undressed, really look at the chest during quiet inspiration for those intercostal retractions, supraventricular tugging. If there's a quiet chest, press in the chest while you're listening to see if you can hear some wheeze. Maybe they're just hiding it. Thinking about why kids get sick from asthma, we talk about it as being a condition that's like breathing through a straw. I think it's a lot more useful to think about this as a problem of hyperinflation. So to illustrate that, everyone take a deep breath and hold it, don't exhale, and then try to resume tidal volume breathing on top of your increased functional residual capacity. And it's really challenging, right? When the chest wall expands, the pressure volume curve shifts to the right, and it takes a tremendous amount of effort to initiate every new breath, which is why these kids develop severe respiratory muscle fatigue and can tire out. Another important difference in pathophysiology in adults and kids is kids are not chronic CO2 retainers and ought to be hypocarbic during an asthma exacerbation, just like you are now. If you see a normal or even an elevated PCO2 on a blood gas, that is a seriously ill kid and maybe a perimortem event. In general, our therapy, though, is going to be essentially identical. We're going to give nebs, steroids, and magnesium. One of the big differences in kids, though, is you want to go to epinephrine much earlier than you would in adults because the risk-benefit ratio is very different than your older patients. The idea is you give epi with the nebs concurrently because the transient bronchodilation from the epinephrine is going to allow you to deliver nebulized medicine to the distal bronchioles in those kids who have really poor air exchange. It's not going to get down there otherwise. And the albuterol is going to last longer than the epinephrine. Another big difference is hydration. We don't think about this as much in our COPDers or adult asthmatics, but kids have less reserve, and they're almost all going to come in hypovolemic because of the increased insensible loss of tachypnea and fever, as well as poor PO during their illness. So an early judicious fluid bolus can help them get better faster. So back to our kid. We give him everything early, right up front, really good aggressive medical therapy, but he's still not getting better and starting to tire out. He's going to need some degree of respiratory support. Now, had this been an adult patient, we probably would have gone to BiPAP right away. In kids, we tend not to because of the technical challenges associated with it, even though there is data, not very high quality, but data that it does decrease the need for intubation in kids and is safe to do. You have to find the right size mask, which requires a good RT. But the real challenge is honestly getting them to tolerate it. Any child with a mental status safe for BiPAP is not going to put it on their face willingly. So having child life or cooperative parents help is useful. You can also consider some light sedation with ketamine or Precedex. That's probably going to be beyond the scope of routine ED management. Nasal cannula, high-flow nasal cannula is something we do a lot for bronchiolytics. It's honestly never been studied in asthma, but something to consider in your back pocket because kids aren't dependent on their hypoxic respiratory drive. It might be a useful adjunct and deserves probably further study. If this is someone you decide you do have to intubate, this is one you want to prepare for. Have a checklist and use it. These kids can be at high risk for peri-intubation hypotension, especially if they're not adequately volume resuscitated. So have them push those pressors, make sure the fluids are going, and get a push-pull setup to deliver a rapid fluid bolus if need be. It wouldn't be an EM talk without mentioning it. But beyond your choice of induction agent, what you really have to do for this kid is make sure you get the tube on the first pass. Any glottic manipulation is going to increase the risk of bronchospasm and air trapping and make them worse. So have your most senior person do it. We all know that tubing isn't really the challenge, it's ventilation, right? And so our general strategy is to maximize the time available for exhalation to avoid dynamic hyperinflation and air trapping. So you want a low respiratory rate, a low tidal volume. We're probably going to have to adjust when we don't usually fiddle around with too much, which is the I time. You want to set as low an I time as possible without elevating the peak pressures to get the breaths in fast and extend your I to E ratio so they can exhale. PEEP is controversial, probably as low as you can get away with, like 3 to 5 to start with. If a kid starts to crump on the ventilator, they're at risk for all of these things. So our general algorithm is going to be to take them off the vent, bag slowly, suction well for any mucus plugs, think about a pneumothorax, and provide manual extrathoracic decompression to help them exhale if they are air trapping. This QR code, if you have time, links to some show notes and extra resources if you want them. But just to recap, kids are not little adults. They're not CO2 retainers. So if you see hypercarbia, that's a bad sign. examine carefully with intention, hydrate your asthmatics, and epi early in those with poor aeration. Thanks.